dysplasia today. So starting with, it was first described in 1938 as a rare cause of renovascular hypertension with string of bead appearance. It is basically a non-atheromatous, non-inflammatory proliferative process. The principal pathology involves basically primarily involves the media and affects the long unbranched segments of medium-sized conduit arteries, such as the renal artery, the internal carotid artery, but it is observed almost in every artery of body. It is most commonly noted in women between the age of 20 to 60 years of age, but it is also seen in men and old persons or pediatric population as well. FMD, as we all know, is the second most common cause of renal artery stenosis after atherosclerosis. It is the most common cause of renal hypertension in young individuals. Usually described, these FMDs are usually described in the arteries such as renal artery, extrarenal carotid, and vertebral arteries. The manifestations involve spectrum of arterial and aneurysmal degenerations and depends mainly on the arterial bed which is involved. And the treatment mainly focuses on medical and conservative treatment, endovascular, surgical, depending on the patient comorbidities and severity and anatomy of the disease involved. So completing with the general overview, I'll go to the etiology. So many hypotheses have been postulated with partial evidence supporting the hypothesis, one of which is vessel wall ischemia. The vessels most commonly affected by fibromuscular dysplasia, as we discussed, are renal, internal carotid, and vertebral arteries. These are basically the long arteries which with very fewer branches, with fewer vasa vasorum. Vasa vasorums are the muscular arteries which supply oxygen and nutrients to the arterial wall and originate from the branch points of parent arteries. So, in the presence of few vasa vasorums, occlusion occurs, induces dysplastic lesions, and leads to the development of fibromuscular dysplasia. So, various things which support this is that repeated stretching during motion and respiration damage the sparse vasovasorum, causing FMD. Also, vasospasm, which might induce ischemia and leading to FMD. Other is mural ischemia due to functional defects in the vasovasorum, which are most commonly noted in these patients. Cigarette smoking has been associated with higher prevalence, and the severity of disease in cigarette smokers in patients affected with fibromuscular dysplasia seems to be higher. The disease is more severe in cigarette smokers. Rare pathologies such as inheritance has been noted by Rushton, and it has Rushton has suggested that FMD is transmitted in autosomal dominant manner with incomplete penetrance and with variable clinical symptoms. Autoimmune origin due to genetic association with HLA-DR-W6 has also been noted. FMD coexists with other diseases such as EDS type 4, which is also associated with medial fibroplasia, then pheochromocytoma, Marfan syndrome, Alport syndrome, and Takayasu's arteritis. Now, getting to the differential diagnosis of fibromuscular dysplasia. Basically, diagnosis depends on the associated phenotypic traits. So, neurofibromatosis type 1 show characteristic skin lesions. Vascular EDS show characteristic acrogenic dysmorphism, skin elasticity, and distal joint laxity. Other is Williams syndrome, which show facial dysmorphism, supraaortic stenosis, and particular behaviors. Differentiating from vasculitis, differentiation between vasculitis and FMD is difficult, and it needs tissue samples and laboratory markers confirming inflammation to suggest vasculitis. Coming to the next slide, classification. Traditionally, FMDs has been classified depending on the pathological layer of the arterial wall affected into intima, media, and adventitia. Medial types have been divided into medial fibroplasia, perimedial fibroplasia, and medial hyperplasia. But with the recent deficit in the tissue sampling for classifying this way, we have proceeded with the angiographic system of classification, and we differentiate mainly into unifocal and multifocal. The unifocal being less female, so less female predominance, and diagnosed at a younger age, and treatment results are usually better. Exactly opposite with the multifocal disease. Going to the next slide. I'm unable to change slides, sir. Just a moment. Just a moment, sir. I am unable to change slide. Yeah, sorry. So classification of dysplasia is basically this is a table from Rutherford. It is divided into intimal fibroplasia and medial dysplasia into medial fibroplasia, perimedial fibroplasia, and adventitial fibroplasia. The intimal medial fibroplasia is the shows highest percentage and is the most common type. Intimal fibroplasia is often seen in young with no gender differentiation, with occurrence of 5 to 10%. The pathological feature is collagen deposition within the intima. Internal elastic lamina may be disrupted, and it is usually of unifocal type with ring-like focal stenosis or a long irregular tubular stenosis. The medial fibroplasia is seen in adolescent and females between the age of 20 to 70, with female to male ratio of 5 to 9 is to 1. It is most common type. 80% cases are noted, with areas of thin medial alternating with thickened fibromuscular ridges containing collagen. Advanced milieu dysplasia, especially in children, also shows secondary intimal hyperplasia. It is usually of multifocal type with string of beads appearance, with the bead larger than the proximal vessel. Normally involves distal two-thirds of the main renal artery, but can also extend into branches. So the proximal is spared in medial fibroplasia. In perimedial fibroplasia, it is usually seen in young girls and women up to age of 50 years. Occurrence is 1 to 5%. Pathologically, it shows patchy collagen deposition between media and adventitia with external elastic lamina being intact. It is usually of multifocal or unifocal type and also results in string of beads appearance. The diameter of the bead does not exceed the diameter of the proximal artery. And the adventitial fibroplasia shows no gender differentiation and is very uncommon. This is the histological picture showing normal renal artery with distinct wall, and the medial fibrodysplasia changes with dense fibrous connective tissue in the outer media and disordered inner medial smooth muscle. Now coming to renal fibromuscular dysplasia, it is the second most frequent cause of renal artery stenosis after atherosclerosis. The most common cause of renal hypertension in young individuals, predominantly noted in the Caucasian women in their 20s to 40s with normal kidney functions. Epidemiology, symptomatic fibromuscular renal artery stenosis is seen in less than in up to 0.4% of the population, but the prevalence of asymptomatic fibromuscular dysplasia in potential renal artery donors is around 4%. It is most often diagnosed in patients between 15 to 70 years of age, but cases of have been reported from infancy to up to the age of 89. The medial type of FMD is the most common type, with 4 times more prevalence in female than in males. In contrast, the less common type, intimal type, is more prevalent in males. The lesion may be bilateral, but in unilateral disease, the right renal artery is most commonly affected. In childhood, renovascular hypertension is important cause of hypertension and seen in up to 8 to 10% of hypertensive children. and up to 25% in those children with secondary hypertension. The pathophysiology basically involves renin-angiotensin aldosterone system as different versus with the atherosclerosis. In FMD, it is mainly renin-dependent stenosis which is noted. There are multiple septae which leads to the reduction in the renal arteries, which together may induce reduction in the renal perfusion, resulting in renovascular hypertension. So renin-angiotensin system is activated, leading to volume expansion and then hypertension. Several mechanisms have been associated with it, which include increased endothelin production, local renin-angiotensin aldosterone activation, arterial wall remodeling, oxidative stress, which help to sustain the hypertension. So not only the renin-angiotensin aldosterone system, as well as the local vasoconstrictive proliferative effects in the arterial wall gradually lead to the resistance to therapy. Inflammatory mediators such as C-reactive protein, tumor necrosis factor, interleukin-6, and neoplatin vasoconstrictive mediators such as ET1 are increased in renovascular hypertension. So in renal perfusion, the renal perfusion correlates with the degree of stenosis, inversely with the degree of stenosis in FMD. In atherosclerosis, it is not so. In atherosclerosis, there is renal primary disease with ischemic nephropathy, which is noted. So, clinical presentation. Renovascular hypertension caused by one or more stenosis of the extrarenal artery is the second most common cause of secondary hypertension. Basically, secondary hypertension is one in which the treatment fails to control the medical treatment management fails to control the hypertension. It occurs approximately in the 2% of the adult patients with blood pressure elevated assessed in specialized centers. In renal artery stenosis, abdominal bruit can be noted with lateralization. Patients with high-grade stenosis in single kidney or bilateral disease with occluded renal artery are usually present with acute pulmonary edema or symptoms of flash pulmonary edema. Presence of atherosclerosis completely rules out renal artery stenosis because of fibromuscular dysplasia, whereas even a slightest of signs of atherosclerotic disease indicates greater possibility of atherosclerotic disease rather than fibromuscular dysplasia. Diagnostic evaluation is done by renal artery duplex ultrasound, gadolinium enhanced MRA, gadolinium enhanced CT angiography, and DSA is the gold standard. DSA rule DSA completely DSA is 100% diagnostic to rule out whether the case is of FMD or not. The intraarterial measurement of pressure gradient across the stenosis is important factor, and renal to aortic pressure ratio of less than 0.9 implies increased renin levels in renal and signifies physiologically relevant stenosis. Treatment selection is basically medical, surgical, or endovascular. The medical part involves in hypertensive patients maintaining the systolic BP between 130 to 139, diastolic less than 90, and in diabetic patient less than 130 to 80. The antihypertensive medication which are used primarily first line treatment in the first line treatment are ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and diuretics. Endovascular treatment is indicated when medical treatment fails and there is unsatisfactory control of hypertension, and the usual treatment is percutaneous transfemoral renal angioplasty. The screen shows a patient with the mid and the distal renal artery showing beads of string of beads appearance, and typically after he underwent PTRA, the main renal artery can be well visualized. Technical considerations during PTRA are use of smaller systems, O14 or O18 systems to reduce the vasospasm. Femoral access is usually used and heparinization is done as usual. Pre-medication to reduce vasospasm can be done, and dihydropyridines such as nifedipine are usually used. Intraoperative nitroglycerin can also be used, and a dosage of 0.15 mg of NTG is given into the renal artery just after catheterization in stable patients. Diameter of balloon is same as the proximal unaffected part of renal artery. If distal branches are affected, multiple guide wires may be necessary and kissing balloon technique can be used. Hypoplastic lesions are at higher risk of rupture, and in complex lesions, cutting balloon can be used. But during using cutting balloon, you have to be cautious whether the lesion is dysplastic or hypoplastic, and you have to start with undersized balloon, and you should be ready to manage the complications such as rupture of vessel. Stenting good results are noted with PTRA, and stenting is seldom required because the patients are relatively young. High rate of restenosis is noted with stenting, and the stenting is usually done when there is procedural complications or there is persistent pressure gradient even after balloon angioplasty, or if there is small aneurysm in renal artery. Complications associated with endovascular treatment involve puncture-site hematoma, which is most common 3% to 26% in general. Then renal artery dissection 1.4% to 6.7%, and rupture of renal artery, branch occlusion or thrombosis of the renal artery. Surgical management is done in patients with severe PTRA complications such as thrombosis, perforation, or dissection, and those cannot be handled with endovascular treatment. And after repeated failures or restenosis after PTRA, and in obviously in large aneurysms. For surgical treatment, the techniques are basically aortorenal bypass or autotransplantation with renal repair. Aortorenal bypass is done with autologous vein graft, and it is preferred in adults. In children, the preferred treatment is autologous hypogastric artery graft. And Dacron or expanded PTFE can be used, but it is not usually the first choice. Autotransplantation is considered when the reoperation for is considered in following situations such as reoperation for failed renal artery repair, failed complex endovascular reconstruction after several attempts, multisegmental arterial dysplasia, and a single kidney and stenosis in several renal arteries. Fibromuscular dysplasia and aneurysms. A large proportion of patients experience small aneurysmal areas interspaced by webs in the renal artery. Microaneurysms are usually not infrequent, and very few patients are noted even in the US registry, where 25 out of 295 patients had aneurysmal changes. Most aneurysms have very low risk of rupture, and only few ruptured FMDs have been noted. Aneurysm size and treatment depends basically 1 to 2 centimeters. The treatment is uncertain, and conservative treatment, or if additional risk factors are there, endovascular surgery is recommended. If in more than 2 centimeter size aneurysms, requires some form of intervention, endovascular or surgical. In pediatric renal artery stenosis, it is the most important cause of hypertension in children. The cause of pediatric renal artery stenosis is usually FMD followed by developmental RAS or vascular neurofibromatosis type 1, Moya disease, vasculitis such as Takayasu, Alagille syndrome, and Williams syndrome. The considerations during endovascular treatment in children that should be kept in mind that they have a greater tendency of vasospasm. The string of bead appearance is not very frequent, and after ballooning, recoil is very common. Suspected hypoplastic renal artery or complex stenosis should be considered for open surgical intervention. Restenosis is noted in less than in almost 1/3 of the patients. Coming to extracranial cerebrovascular fibromuscular dysplasias, noted mainly in the carotid and vertebral arteries. Very uncommon, even 0.42% in 3,600 patients undergoing cerebral arteriography examination showed extracranial cerebrovascular FMDs. Usually are silent and present only with cerebrovascular symptoms, if at all they present. Whichever cases are reported, 35 to 85% were bilateral, and it is most common in women 40 to 60%, 60 years of age, between 40 to 60 years of age. With carotid FMDs, complications can occur because of the encroachment of the arterial lumen, causing reduced perfusion or formation of an embolus, embolization due to a thrombus, or due to dissection, or due to rupture. Intracranial FMDs are the most common type in carotid FMDs, and it is because of mainly medial fibroplasia. They show string of bead appearance, and 80 to 95% of the lesions are seen. Usually the proximal part is not involved and the middle and distal part of ICAs are involved, and that is the tricky part in the treatment. On external surface, on external examination, serial stenosis are also noted in few patients. The artery is often elongated and tortuous, and kinking occurs in approximately 5% of the cases. External carotid FMDs and intracerebral arterial FMDs are also noted, which can also be concurrently noted in intracranial internal carotid artery aneurysms as well. Carotid FMDs are concurrently seen with atherosclerotic lesions, as opposed with in renal cases. Renal cases do not show at all atherosclerotic changes, but in carotid FMDs, atherosclerotic changes are do noted. Extracranial carotid artery aneurysms are also common. Carotid artery dissections are common. Vertebral artery FMDs are common. Vertebral artery aneurysms are FMDs are usually isolated finding and located at the C2 vertebral body level and does not extend intracranially. Intracranial aneurysms and occlusive disease are seen in 10% of the patients with FMD in general, and 51% patients with internal carotid artery FMDs in particularly. They tend to be on the same side as extracranial carotid FMDs and may rupture or hemorrhage after the proximal stenosis has been relieved after surgical or endovascular intervention. So, like I said, the majority of the these carotid FMDs remain silent, and no optimal method for invasive follow-up of this lesion is to reliably get progression has been any determined. Clinical presentation are by a neurological event or by an incidental finding. They present with TIA, strokes, or disabilities. Non-specific symptoms such as dizziness, headache, altered mentation, pulsatile tinnitus, neck pain, headache, and whooshing, swishing sound in the ear you should be cautious about these features, and carotid FMD should be ruled out, especially in young patients which show no risk factors of atherosclerosis. Diagnostic evaluation is done by Doppler duplex ultrasound, which may reveal raised PSV, but these lesions being more commonly seen in middle and distal part. Distal artery cannot be visualized. Standard arteriography is excellent in delineating the anatomical features of the extracranial cerebral artery. CT angiography and MRI angiography can also be done. Treatment selection, basically asymptomatic patients are treated with antiplatelets for stroke prevention. Symptomatic treated with dilation of responsible arteries, and intractable headache is one of the rare indications for invasive treatment. Therapeutic challenges, like I said, it is the middle and the distal part of the artery which is affected. So that is the challenging part in treatment of these patients. In case of concurrent disease, you have to be cautious about if there is any intracranial aneurysm associated with it. When symptomatic carotid FMD is treated, it is challenging to decide how to manage the contralateral side, which is asymptomatic but shows severe, which appears severe on arteriography. So, yeah. So, considerations during treatment should include the landing zone, which is used for during the endovascular treatment for flow reverser devices, and proximal occlusion of CCI and ECI may be the best method of protection during percutaneous intervention. Stents are not usually placed, and routine replacement percute atherosclerotic stenosis of the carotid bifurcation is also noted. And stent placement after PTA helps stabilize the flaps and disrupted dysplastic tissue filling. So medical treatment usually involves antiplatelets. Other arterial pathologies should be ruled out and treated if needed. They are monitored every 6 monthly with non-invasive studies such as Doppler ultrasound or CT or MR angiography. Mechanical repair can be done with 3 techniques. That is, one is open surgical graduated rigid dilatation. Then open access for transluminal balloon and dilation with proximal clamping and black bleeding to avoid embolization. The third technique is with the percutaneous transluminal angioplasty. Open surgical dilation is done. Basically, the usual dysplastic lesion encountered is managed with this technique and responds to mechanical dilation. Rigid dilators of progressively increasing size are passed antegrade into the internal carotid artery after slinging and stretching out the internal carotid artery. So the image shows basically how it is done, mechanical rigid dilatation. You go progressively dilating the internal carotid artery and after stretching the artery, and let the blood, after back bleeding, let the dislodged debris come out of the arteriotomy. Complications associated with this are basically perioperative stroke 1.4 to 2.6%, TIA 1.4 to 7.7%, cranial nerve injury which is 5.1 to 16.7%. Primary patency survival and stroke-free survival were at 5 years 94 to 96 to and 94%, and at 10 years were 94, 82, and 88%. So the results are good. Open access balloon dilation is another technique which combines open arterial proximal control when the disease extends far too distally to be dissected. Adequate control of the vessel is ensured, and then it is done. Controlled dilation is done in this open access technique while maintaining the ability to give a decent black bead. Advantage is that embolization of debris into the central blood flow is avoided. And third is percutaneous transluminal angioplasty, which is preferred for more proximal internal carotid artery fibromuscular dysplasias. Lesions with signs of aneurysm should not be considered for percutaneous technique, and lesions that show even some amount of dissection should be considered for stenting. So this is how it is done. You basically place the catheter in the common carotid artery, go into the park into the external carotid artery after exchanging into stiff wire. You go to the internal carotid artery, place a distal protection device such as ambo sheet or something, and then you do a angioplasty. After angioplasty, you can see the vessel showing good luminal dilatation. Thank you. That's it, sir.